and a revised homework schedule too, so that we'll all be on the same page. But essentially, we were going to start the digestive system chapter before spring break, but now the Thursday before spring break will be the exam, so you'll have a nice relaxing week, right? And then we'll come back and we'll get started again, so you won't have any studying to do. Now, I do know that sometimes people like to stretch spring break a bit, okay? So if you already have travel plans that include that Thursday, you can take it early. I will give you the exam early, should you choose to do that, because it was originally scheduled for that Tuesday, okay? So if you have plane tickets or whatever, come talk to me about that. Okay. Oh, well then nobody should be extending it the front end anyway, right? We're going to be missing that OChem test too. Okay, so last time we went over this very meaty stuff, and I'm not going to go over it again, but I do want to highlight its importance. You should know what the pressure differentials are like when all four valves open and close, okay, because that's what makes them work. You know, these valves, if you were going to redesign the human being, you could design valves that had muscles attached that closed and opened the valves on purpose. We don't have that. The valves open and close because of pressure either pushing them open or slamming them closed. Okay, so it's all about pressure differences. And I did say last time that valves make a sound when they close, but not when they open, at least in the healthy case. So it's just like a door. It makes a sound when it closes, but when you open a door, it's pretty quiet. So the four valves close two at a time, okay? So both AV valves close, so the bicuspid and the tricuspid close at the same time, and both of the semilunar valves close, so the aortic valve and the pulmonary valve close at the same time. Okay, they also open at the same time, but we don't hear that. So we hear, when we listen to the heart of a person, we hear, you know, lub dub, and then time, and then lub dub, and then time. Well, that first heart sound, the lub, is when the AV valves close. They are larger valves, so typically the lub is a little louder than the second heart sound, than the dub. So we call this S1 and S2. So S1 is the first heart sound, S2 is the second heart sound. And S2 occurs here when the two semilunar valves close and they snap shut and they make a sound. So in the healthy, normal heart, we hear S1, S2, and then a pause in diastole, and then S1, and then S2, and then a pause. Now, there are two other heart sounds, S3 and S4, which are not normal, but are heard in some people for various reasons. Okay, so S4 we hear just ahead of S1, and it's the sound from blood flowing through the relatively restricted space of the AV valve from atrium to ventricle. Okay, so we hear a kind of whooshing, a quick whooshing sound. And then S3 is heard when, as blood is flowing into the ventricles when the AV valves open. So S3 you often will hear in athletic hearts, for example, because their hearts work so well, you'll hear that blood whooshing into the ventricle prior to contraction. And on your own time, there are these, you can hear an S3 and an S4. It doesn't sound right in the room, though. You have to put your headphones on and really listen. So that's embedded in the PowerPoint if you want to look or listen to those. All right. Okay. This should be doing something. What should it be doing? Play. All right, hold on a minute. Oh, the cardiac cycle thing isn't working. I'll play now. Yes, okay. those of you who download this, was this not playing in your download either? Okay, I'll post this. Okay, from current slide. Let's give it some volume. Back here. How come it's not playing? Okay, well, I'll just have to walk you through it. Okay, so at the beginning, or the ventricles start to contract, and you see the AV valves close right here, right? So blood's trying to go back this way, and it pushes this valve closed. And at that same time, the semilunar valves are still closed. So everything is, here, let's back it up a minute. Boom. So both valves are closed for both chambers. So if the entrance is closed and the exit is closed, it means no blood can move, right, in that phase. That's that isovolumetric contraction. The heart is contracting, it's building up pressure, but it isn't actually getting smaller. It's not moving anything yet, okay? Now, once the pressure inside the ventricle exceeds the pressure in the aorta or in the pulmonary valve, then we'll see that valve open. So now the heart gets smaller, see how it gets smaller, and blood is actually pushed out of the heart and into the circulation. So we call that ejection. So the heart is now contracting and getting smaller, pushing blood into either the pulmonary artery, which is here, or the aorta, which is up here. Okay. Then the heart starts to relax. So you see the ventricles relaxed, right? So they got bigger. And at some point, the pressure up here becomes greater than the pressure down here, and this valve closes. So it makes the S2 sound. And now, once again, the heart's entrance and exit doors are closed. So this is that isovolumetric relaxation. The heart, the pressure is going down, but the heart isn't changing size. No blood is moving. Okay. So then, so that continues. You see the valves are closed now. The ventricle continues to relax. Well, here it's AV valves are closed. I already talked about that. And then as the ventricles continue to relax, at some point, the pressure in the ventricle becomes less than the pressure in the atria, and the AV valves open again. And now what you'll see is blood from the atria is going to flow quite quickly into the ventricles. So blood's going to flow down the pressure gradient, right? And then eventually, now the atria are going to kick a little. They're going to kick the rest of that blood into the ventricle, and now the whole cycle starts over again. So we have contraction and ejection, and then relaxation, filling, that's filling, and then that cycle repeats over and over again. And I'll post this on Angel so that you can get at it. I was not sure that, or didn't understand that it wasn't embedded like it should have been. Okay. Okay, so get your devices out. So blood flowing into the heart from the vena cava flows next through which valve? And that box diagram that I drew last time, that's a good reference for questions like this. You know, what's the flow of blood through the heart? In what order do things happen, and what does the blood flow through? And there is certainly some studying to be done on that. Got a wide range of answers. Okay, so that's the right AV valve. So from the vena cava, that empties into the right atrium, right? Between the right atrium and the right ventricle, so the next valve that passes through is going to be the tricuspid valve, that right AV valve. Then from there, it will go through the pulmonary valve into the pulmonary arteries, out to the lungs, and back from the lungs into the left atrium. From the left atrium to the left ventricle, that's where the bicuspid valve is, also called the mitral valve, okay? And then from the left ventricle out into the aorta, it's going to pass through the aortic semilunar valve, right? So know that cycle. All right, the function of the atrium is to do which of those things? I think 12 is our magic number today. All right, so the best answer there is E. So the atria do collect blood. You'll notice in the structure of the heart, there is no valve between the inferior and superior vena cava and the atria, right? The doors to the atria, both left and right, are open all the time. So even while the heart is busy contracting and pushing blood into the circulation, blood that's coming back to the heart from either the body or the lungs collects in the atria all the time because there is no valve to block that. Okay, so the atria are always open. And that actually plays a significant role because most of the blood for the next contraction arrived to the atrium during the last contraction, right? So there's this constant from atrium to ventricle and out, all the while the atrium is filling again, like that video showed. So it does collect blood. It also pumps a little. You know, it's a little at the beginning of the cardiac cycle to finish filling up that ventricle so it can be nice and big to contract. All right, when the semilunar valves close, the AV valves, then what? Got to think this one through. So think, where in the cardiac cycle do the semilunar valves close? And then what happens next to those AV valves? Good. More than half of you picked the correct answer, which is B. They open. So the aortic and pulmonic valves close to keep blood from flowing backwards into the ventricle. And then eventually the ventricle relaxes enough where the pressure in the atrium becomes greater than the pressure in the ventricles, and the AV valves then open. So good. Okay. Okay, so the rest of, I'm going to turn this light so I can jump it Steve in the dark. As does everybody. Okay, so the rest of this chapter now is going to take this cardiac cycle and put it together with the blood and the blood vessels to create a system that actually moves resources around the body. Okay? So one of the ways, the heart's principal job is to pump blood. We all know that. Okay, but what does that mean? It means it has to push blood out of itself and around the whole circuit and back to itself so it can pump it again. So we call that concept cardiac output. Okay, cardiac output is the amount of blood the heart moves every minute. Okay, so it's a per unit time thing. And we can figure out cardiac output by two variables. Heart rate, that's pretty straightforward. That's how many beats per minute of the heart does the heart make. Stroke volume is a little more obtuse. Stroke volume is in each heartbeat, how much blood does the heart move, right? So, for example, let's say the heart pushes out 100 milliliters of blood each time it beats, all right? So we know that. If it's then beating 100 times a minute, we have 100 times 100 is the cardiac output. So we have 1,000. So we have a liter. We have 10,000, right? 100 times over again. So that is cardiac output, heart rate times stroke volume. Okay, and of all the measures of the heart's function, cardiac output is the most important because it tells us how well is the heart doing its job. Its job is to move blood. All of the other things it does, it has to do to move that blood, but the ultimate, the bottom line is how much blood does the heart move. So for example, we diagnose heart failure by a cardiac output that is too low for the body's needs. So the heart isn't keeping up with the body's demands. Okay? So in our example here, we've got 75 beats per minute, 80 mLs per beat. That makes about 6,000 or 6 liters per minute, which that is a very normal average cardiac output. Now, the normal range for cardiac output is very wide, though, because people are different shapes and sizes. They're in different degrees of fitness. So what your normal is may not be the same as somebody else's. It's not like the chemistry lab tests like sodium and potassium, which have a very narrow range of normal. The range is going to vary. And this number, of course, changes depending on what you're doing. If you're sprinting, this may go up by 10 times. It may go up to 60 liters per minute. If you're stone cold asleep, it may drop to half of that as your heart beats less and has less to do. Okay. So we're going to talk about both of these aspects as we go forward here, heart rate and stroke volume. So what sets the heart rate? Many people will say, well, doesn't the brain do that? No, the heart is an independently functioning organ. It does not require a functioning brain to operate, okay? It establishes its own heart rate, its own pace. Now, the brain and its autonomic nervous system can turn that pace up or down, but the heart is going to contract as long as it has enough oxygen and nutrients to do so, whether the brain is intact or not. Okay, so in order to have the heart rate create stroke volume, in other words, to get the heart to actually move any blood, a couple of things have to happen. So, what do we need? What do we need to make the heart function properly? Well, both atria should contract together. Now, why together? If you look at the shape of the heart, it's symmetric. There's a right side and a left side, and they kind of look the same. If we have both atria contract at the same time, they assist each other. If one atria contracted and the other was relaxed, the contracting atria would have a tendency to push on the relaxing one. So they have to push on each other in order to function properly. So we need both atria to contract. We need, I'm going to do this one, both ventricles to contract. And then ultimately, we need to have atria first, ventricles second. In other words, this needs to be timed. Because the atria need a chance, contraction takes time. So the atria, in order to push blood into the ventricles, they need to go first and contract. There needs to be a little pause, and then the ventricles need to contract next. And they, too, need to contract at the same time. Bless you. And then the fourth thing we need is cells contract at once. So the heart is made up of, thousands or tens of thousands of cardiac cells. And to have atria contract and ventricle to contract, those cells kind of need to contract at the same time, right? Otherwise, if you've got one group of cells contracting and another group of cells relaxing, they're just going to push on each other. They're not going to push on the blood in the ventricle. So the way we accomplish all of these things is through the conducting system, okay? So built into the heart are specialized cardiac cells. These are not nerve cells. So even though we're going to talk about an action potential, these are not nerve cells. They're muscle cells that have evolved to be specialized for transmitting an action potential. So it's sort of like it's similar to what happens in nerve cells, but instead of having a cell body with a long axon, these cells all are in like a chain. So they pass the action potential from one cell to the next until they get where they're going. And this whole heartbeat system, it starts at this region right here called the sinoatrial node, or SA node is how most people refer to it. It sits just a little anterior to where the superior vena cava enters the right atrium. Okay, so this is the AV node. This is the pacemaker of the heart. Okay, in the normal healthy heart rate is established by these cells right here. Okay, so the critical spot in clinical anatomy, the sinoatrial node. And the trigger for contraction begins at the SA node, and it does so by a pacemaker system. In other words, every unit time, these cells depolarize. They create an action potential all by themselves. The nervous system didn't say beat. These cells just do that. It's like they're riding a bike all the time. They're doing the same thing over and over, and they cause this contraction. All right, so that initiator for contraction, that action potential, which you all learned about last semester, it travels through these specialized pathways to all the rest of the heart then. Okay, so the next step from sinoatrial node is into the atria. So the path that this signal takes from SA node to AV node, which we'll talk about in a minute, we call these the internodal pathways. Okay, so this is where the signal for the atria to contract is going to be carried. Okay, so the SA node fires, that signal sweeps across the atria. The next thing that happens is the atria contract in response to that stimulation signal, right? Well, eventually that contraction signal arrives in the center of the heart. I call it the center because it's between the atria and ventricles, and it's between the left and right side. Okay, so it's in the center. We have another node called the atrioventricular node, or the AV node. Okay, atrio is atrium, ventricle is ventricle. So this is basically the node between the atria and ventricles, right? The AV node. And in this AV node is where this component happens, right? So we'll say AV node right here. Because in the AV node, the signal, that came from the SA node, that came from this spot here, right, arrives here and it gets delayed. So there's an intentional delay. The signal takes time to pass through the AV node, and that gives the atria a chance to contract before the signal is sent to the ventricles to contract. Okay, so we're getting through our list of what do we need. The atria contract because of the SA node and internodal pathways, right? Then we get to the AV node where there's a delay. That allows the atria to go first and then the ventricles to go second. And then from the AV node, now we get down into sending that signal to the ventricles. And the path is a little bit long. So the signal goes down the center of the heart through the wall between the ventricles, and then it's going all the way to the apex, to the pointy part, and then it's going to wrap up and around and next to all of the cells of the ventricles. So it kind of goes down through the middle, and then it sweeps back up the outside. Well, that path through the septum, through the wall between these, the first branch here, which is called here, this is the AV bundle. So arising from the AV node is the AV bundle. It then splits into two big branches, a left branch and a right branch. We call those the bundle branches. So a bundle, the AV bundle, branch, so they have the bundle branches. So we get left and right bundle branches. And they end in these little wispy fibers that look a lot like axons for neurons. But we call those the Purkinje fibers. So these guys out here are the Purkinje fibers. And the Purkinje fibers are what actually carry, or the Purkinje fibers trigger ventricular contraction. Okay, because once the signal has gone from here down through the AV bundle, through the bundle branches, and it gets out here, now we're getting next to heart muscle where that is going to trigger contraction. Okay, so both ventricles to contract This is due to the AV bundle. Bundle branches. We usually just say BB. Bundle branches and Purkinje fibers. Okay. So that gets the ventricles to contract. Well, what about this last one? The cells all contract at once because of gap junctions. Right? And we talked about that when we started this chapter, how the cardiac muscle cells are linked. Ions can pass from one cell to the next. So in the end, we satisfy our 4 needs for the heart, in part because of this conducting system. Okay? So this is what establishes the heart's rhythm. And one of the most problematic things that happens to the heart when it goes wrong is it comes out of rhythm. You know, so like on TV, or you may have seen it live in person, somebody clutches their chest and drops to the floor, right? Well, they've had a heart attack. Oh, they've had a heart attack. Well, yes, they've had a heart attack, but what's actually killing them right now is that their heart is either not beating or it's beating in a strange rhythm, in a non-functional rhythm. You know, so in come the guys with the paddles and they shock them, right? Clear. Well, when you shock the heart, it resets this conducting system and can sometimes get a stopped heart beating again, okay? So this conducting system is not trivial anatomy. You know, this is, got to know this stuff because many of you are going to go on and take care of patients someday, and there are a lot of things that affect this system, and this system is the center of a lot of cardiac pathology, okay, the conducting system. And I don't really think it's that complicated. You know, you've got the SA node establishes the rhythm, right? How often per minute. The internodal bundles cross through the atria to activate them. The AV node has that delay, and then we go down into the septum with the AV bundle, the bundle branches, and then up into the muscles, or into the muscle cells with the Purkinje fibers. All right, yes?
What causes that pause in the AV node?
The cells are literally slow at transmitting that signal compared to the rest of the system. So it results in, it's about 100 millisecond delay to give the atria a chance to contract before they go on down. All right. So this just shows you that same information, different pictures. So SA node fires, that signal, which is shown in purple here, sweeps across the atria. As the atria start to contract, see that's the green arrow. So first they're stimulated, then they contract. It doesn't happen at the same time, okay? While the atria are contracting, the AV node is holding that signal for its 100 milliseconds. And then it releases that signal down through the bundle branch to the left and right, or down through the bundle, and then the bundle branches, and then up into the Purkinje fibers. And now you see that the ventricles are being stimulated, that's purple, and next they're going to contract, okay? So this is sort of the conducting system at work, okay? This moderator band that you see it's just a little extra sort of branch of a bundle branch that crosses over the top of the right ventricle. It's a little esoteric human heart thing, the moderator band. It doesn't really moderate anything. At first, they didn't really know what it was, but it's just it's like an extra bundle branch on the right side. Okay. So a key point right here, you might want to circle this. First, the cells of the heart, first they depolarize, then they contract. Okay, because when we start looking at the EKG in a minute, a very common mistake is to think that depolarization is contraction. It's not. In a sick heart, for example, you can get this depolarization, this stimulation, and the heart never contracts. You know, so you've got a patient who has an EKG, you can see this signaling happening, but the heart isn't actually contracting. You know, it's why you never trust an EKG to tell you if the heart's really pumping blood or not. That's what a pulse check is for. Because you can have a conducting system working just fine and heart just sitting there not beating at all. All right. And I think this is another lost video here. And see, that one's not there either. Okay, this is conducting system. And here, that's why we didn't have volume before. Okay.
In the sinoatrial node.
Hold on, I'm going to back them up.
Across the wall.
There. I'll get them. Yeah, would you please? Thank you. I'll just ask you.
Potentials originate in the sinoatrial node and travel across the wall of the atrium from the sinoatrial node to the atrioventricular node. Action potentials pass slowly through the atrioventricular node to give the atria time to contract. They then pass rapidly along the atrioventricular bundle, which extends from the atrioventricular node through the fibrous skeleton into the interventricular septum. The atrioventricular bundle divides into right and left bundle branches, and action potentials descend rapidly to the apex of each ventricle along the bundle branches. Action potentials are carried by the Purkinje fibers from the bundle branches to the ventricular walls. The rapid conduction from the atrioventricular bundle to the ends of the Purkinje fibers allows the ventricular muscle cells to contract in unison, providing a strong contraction.
All right, so that's, you want to hit those lights for me again. So that's the conducting system. Okay, so the conducting system is a way for many cells, because the heart's made of many cells, to all be sort of fed a contraction signal very rapidly, right? So it works like a set of wires. You can send information very quickly. Well, once that stimulus for contraction has been sent out, the next thing that happens to the cardiac muscle cells is they depolarize, which hopefully you remember from the same thing nerve cells do, right? Their membrane potential changes, so we call that depolarization, and that is an electrical phenomenon. Okay, so electric charge is moving around, which means that we can detect that change in electricity using an electrode. So probably everybody in this room has had the leads put on at least once where they check your EKG, or not a formal EKG, but you put you on the monitor. Okay, so what we're seeing through those electrodes is not the conducting system. Okay, common error. You're not seeing the conducting system in the EKG. You are seeing what it accomplishes, and that is depolarization of the atria and the ventricles. Okay? So we call that pattern of electricity that we can detect at the skin the electrocardiogram. And it was invented in Germany where cardio is spelled with a K, so sometimes it's EKG, sometimes it's ECG. But ECG is the better abbreviation here, anyway. And what we'll see is that each part of the EKG shows us something different about the heart's electrical change. And I'll say it again, not its contraction. Okay, this is all electricity. Moving blood takes physical work, right? It takes force to move blood. Electricity can do all at once, but unless the heart is responding to that electrical signal, the patient may not have a pulse at all. Okay, but what do we see in the EKG? So this is very typical. We have a bump, we have a sharp peak, we have another bump, and then it repeats. Okay, so this is time across here. Okay, so the x-axis is time, and y is electrical change. It's voltage, technically. So this first wave, we call it the P wave. Why? Because that's how it is. We started with the letter P. Who knows why we didn't call it the A wave, but we didn't, or medicine didn't. So we have the P wave starts it. And the P wave shows us electrically the atria depolarizing. Okay, so it shows us this phase right here. So you could say this is the P wave, generating the electricity, the electrical change that's then detected here. Okay, then there's a little pause. That's the AV node again, right? Because the atria have to have a chance to contract for the ventricles to contract. So this is the AV nodal delay between the P and the QRS. The big tall curve we call QRS because first it goes down, then it goes up, then it goes down, then it goes up again. So it has three peaks, technically. So we call this the QRS complex. This is showing us ventricular depolarization. So it's showing you this part right here. This is what you see in the QRS. Okay. And then we have another delay, and now we have a bump again, the T wave. This is when the ventricles are repolarizing. Okay, so depolarization is the signal for contraction. Repolarization is the signal for relaxation. Okay, so as the ventricle starts to relax, the cells repolarize, and we get another bump that we call the T wave. And then we get the next one, so P, QRS, T, and so on. Okay, so where is contraction occurring in the healthy heart? You know, you take a pulse, and if you pay close attention, you'll see that the atria contract here between the P and the QRS. The ventricles contract here between the QRS and the T. All right. So we see the atria depolarize. We see the ventricles depolarize. We see the ventricles repolarize. So you might say, well, aren't we missing something? Where is atrial repolarization? Why don't we see it? Right? Because at the same time the ventricle is depolarizing, the atria is repolarizing. So it's buried in the QRS. The atria are so much smaller than the ventricles that we don't see their action electrically if the ventricle is doing something else. So the atrial repolarization is sort of hidden in here somewhere. All right. And I think in lab you're going to look at some EKGs, at least I hope you do, to get some practice with what these mean. So this is what normal looks like. So you've got atria contracting or depolarizing, ventricle depolarizing, and then repolarization. Okay, so, yeah, huh?
Which is a signal for relaxing.
Yes, repolarization is the same thing as the heart is starting to relax, the ventricle is starting to relax. Good. So you should know what the P wave is showing you, the QRS is showing you, and the T wave is showing you. Okay? All right. KG in a nutshell. All right. Okay, so, you know, we talked a little bit. Can you turn that front light off again? Because it's getting washed out. Okay. So cardiac muscle down here, skeletal muscle. We've already talked about some of the things they have in common and some of the things that are different. What this is showing you is this is what you learned about last semester. This is skeletal muscle, you know, and you get stimulus from the nervous system, and then what follows is a short contraction, right? That would you talk about twitches, muscle twitch. That's a muscle twitch. Okay. So stimulus response. The heart has evolved differently. You know, skeletal muscle needs to be quickly responsive and quick to contract and quick to relax, right? Otherwise, we wouldn't be able to do all the complicated things we do. The heart doesn't have to be quick to do anything. It has to be consistent, right? So for the heart, the action potential and the response to that action potential look very different than they do in skeletal muscle. So where skeletal muscle gives you a twitch, heart muscle gives you this long, slow contraction followed by an equally slow relaxation. So it's a powerful, slow thing compared to the quick, responsive thing of skeletal muscle. And the reason for that is because of this action potential shape. You know, here we have up and down. Well, in the heart, we have up, and then it stays up, and then it slowly goes back down to baseline, and now it's ready to contract again. So we have this part here called the plateau, right? A plateau is a flat part of a mountain, so this is a plateau of the action potential curve. And you see that contraction starts when the action potential goes up, but it takes time to build, and then it takes time to relax. That's classic, sorry about that. That's classic cardiac muscle. It's powerful, but it's slow to get going, okay? So why does this make the difference? Well, in this plateau phase in cardiac muscle, calcium channels are open. And if you remember from skeletal muscle, calcium is the trigger for contraction, right? Calcium moves that tropomyosin, troponin complex away from the myosin heads, and things can start to happen, or away from the active sites. Well, cardiac muscle works because of calcium too. When calcium enters the cell, it triggers the release of calcium from inside the cell too, because heart muscle has sarcoplasmic reticulum, if you remember that. And as that calcium is entering during this plateau phase, that is the trigger for contraction. Okay, so calcium enters here, and lo and behold, as the calcium enters, yep, here's the contraction beginning. Okay, the calcium channels close about here, and the membrane potential starts to go back to normal. And what do we see? Well, now the heart's relaxing because the calcium is going away. It's being resequestered back into the sarcoplasmic reticulum. So this action potential shape explains how cardiac muscle works down at that cellular level. Okay, calcium comes in during this plateau phase, and that triggers contraction. All right, and it means some other things that the book will talk about, but that's really the key of it. Is this flat part, this plateau, is where calcium is entering, and that calcium then triggers contraction. Okay. Man, there's a lot of material in this chapter. Forgot about that. Okay, so we talked about the SA node and how it controls heart rate. Well, it doesn't live on an island. The sympathetic and parasympathetic nervous system can affect it. And the short version of this is the sympathetic system, which is down here, has the net effect of speeding up the SA node's contraction rate, right? So do you see here we have 4 peaks and valleys, and here we have 5. So the heart rate has gone up by 25%, right? So we have a faster beating heart. And the reason it has changed, if you look at what's different between this graph and this graph, it's that the instead of going down to -60 between beats, which you see here, it only goes down to about -45. You see how this is quite a bit higher than 60? The net result of that is a faster heartbeat. Because the way this pacemaker works is these cells are leaky to sodium. So so we've had a heartbeat, that's here, and it goes back down to here, but it doesn't stay there. Sodium leaks in, that causes the membrane potential to slowly go up. When it crosses its threshold, then it sends an action potential and goes all the way down, but then it leaks again, and we get that over and over again. So that's how the pace gets set, is how leaky are these SA node cells to sodium. The faster the leak, the faster the heart rate. And the sympathetic nervous system modifies that by controlling not how leaky it is, because that's set for every individual, but how far down below the threshold the heart goes in between, right? So here it goes down to -60, here it only goes to 45. The parasympathetic nervous system has the opposite effect. It drives that membrane potential down even further between beats. So see, now we're down here at -70, which means it takes that much longer to leak its way up to threshold and throw another action potential, right? So all those sympathetic nervous system and parasympathetic nervous system modifying drugs that you all will learn about in your futures, almost all of them have some effect on heart rate, particularly how far down this depolarization is in between beats. Okay, so heart rate control in the sympathetic and parasympathetic nervous system. And I think I'll introduce this and we'll do all the really hard stuff next time. Okay, so I said cardiac output is 2 things, stroke volume times heart rate, right? How fast the heart beats times how much blood is moved in each beat. Well, what is stroke volume? That's how much blood is moved in each beat. This is sort of showing you that, comparing it to a water pump. Okay, so we'll start here. And first, before you can pump any water, you've got to pull water into your pump, right? Otherwise, you're not going to move anything. Well, the equivalent thing of pulling water into the pump is when the AV valves open, the ventricles fill with blood, right? So blood coming back from the heart goes right into the ventricles, ready for the next contraction. At some point, the atria will have contracted, and the ventricles will be as full as they're going to be in that cycle, in that cardiac cycle. So we get this important number, which is the end diastolic volume. Okay, take that apart. Diastole is relaxation. You know what the end is. Volume is how much blood is in the heart. So this is the volume of blood in the heart at the end of relaxation, at the end of diastole. The easiest way to think of it is EDV is the largest the heart will be in that contraction, in that cardiac cycle, because it's all full. It's been filled up with blood coming back from the body. It's been filled up with blood that gets contracted into it, gets pushed into it from the atria. And when the ventricles just start to contract, they are at their fullest. So that's end diastolic volume. Okay, so the pump is full. Now we start the contraction cycle, right? So now we're going to push down on that pump. The ventricles are going to squeeze blood into the atria, or into the aorta and into the pulmonary arteries, and blood's going to get ejected from the heart. Remember, we called that ventricular ejection. So that goes on for some time. At the end of that cycle, though, the heart will have squeezed as tiny as it's going to get. It will have pushed as much blood as it's going to get out that cycle, and now it's at its smallest, right? So biggest heart size, smallest heart size. Because in a small heart, everything's contracted and pushing the heart. So the volume of the heart at the end of that systole, we call that end systolic volume. So biggest the heart gets, EDV, smallest the heart gets, ESV. Why do we care? Because that's how we calculate stroke volume. We take the biggest the heart is and subtract the smallest the heart is, and the difference is the amount of blood that got pushed out. So is the stroke volume. So we're gonna next time we're gonna put some of these different factors together. How because all these things change. Heart rate changes, end diastolic volume changes, end systolic volume changes. So stroke volume changes. It's to be elaborate, as we'll talk about next time. Okay? So questions before we go? And I'm always open for questions after class, too. Y'all know that. All right, so onward next time into integration. We're going to put it all together. Right, 120 over 80. So the first number is the systolic pressure. So that's when the heart's contracting. And the 80 is the diastolic pressure when the heart's relaxing.
Why is that smaller? You know how if the heart's relaxing and that's how there's a lot more blood in it? Why is that smaller?
Because the heart isn't pushing on the blood system.
Oh, so that's the pressure.
Right. When the heart's pushing, that pressure goes up. When the heart's relaxing, the pressure goes down. So right, we're talking about pressure, not volume.
Blood pressure.
Yes, blood pressure. Yeah.
Okay.